Hello, students. Welcome to the chapter related to concepts of care for patients with hematologic problems. So, we are going to review the key terms: anemia, a reduction in the number of red blood cells, blast phase cells, immature white cells that are dividing rapidly. So remember, we have to be familiarized with the previous chapter. There is a diagram that talks about the pluripotent stem cell and then the committed cell, and they branch into two categories: the ones that are coming from the marrow, the myelo cells, versus the lymphoid cells, right? So blasts are in the in the part of the diagram that talks about the myeloblast cells, okay? Engraftment, the successful take of the stem cells transplanted into the recipient, erythrocytes, red blood cells, glossitis, a smooth, beefy red tongue, hemoglobin A, normal adult hemoglobin with 2 normal A change and 2 normal B change. Let's remember, or let's do a rapid refresh. Any adult has two parts of hemoglobin A. A is coming from adult, and two normal beta chains, okay? B as beta. Okay, the hemoglobin F is in reference to the fetal hemoglobin. Hemoglobin S is S as sick cells, right? The hemoglobin of sickle cell disease, in which there are two normals A and two abnormals beta change, which in adults is going to be two normal beta chains. In fact, this hemoglobin S makes the cells to fold poorly, causing the red blood cells to assume a sickle shape under the low oxygen conditions. Because if the hemoglobin is normal and enough, we know that the hemoglobin carries the oxygen. So the cells are going to be in nice volume, nice donut, really, nice rounded shape. When there is no good hemoglobin, of course it's going to reduce the amount of oxygen within the cell, and the cells is going kind of to fall, is going to to fold poorly because of the lack of oxygen. Hemolytic, blood destroying, intracellularity, cellular excess in the peripheral blood, indolent, slow growing or slow to progress, intrinsic factor, a substance normally secreted by the gastric mucosa that is needed for intestinal absorption, leukemia, blood cancer that results from a loss of normal cellular regulation, leading to uncontrolled production of immature WBCs, blast, right? Leukocytes, white blood cells, leukopenia, reduction in the circulating number of white blood cells, lymphomas, cancer of the lymphoid cells, and tissues with loss of cellular regulation. Malignant is cancerous. Multiple myeloma, a white blood cell cancer of mature B lymphocytes called plasma cells that secretes antibody. Nadir, the period after chemotherapy in which bone marrow suppression is the most severe. Pancytopenia, a condition of low circulating numbers of all cell types, meaning reduced number in RBCs, in WBCs, and platelets. Perfusion, adequate arterial blood flow through the tissues, peripheral perfusion, and blood that is pumped by the heart, central perfusion to oxygenate body tissues, peripheral blood stems, cells that have been, those are the ones that have been released from the bone marrow and circulate within the peripheral blood. Pernicious anemia, anemia resulting from failure to absorb B12 caused by deficiency of intrinsic factor. The Philadelphia chromosome, an abnormal chromosome often associated with chronic myelogenous leukemia. Polycythemia vera, one of the chronic myeloproliferative neoplasms in which there is a loss of cellular regulation and excessive proliferation of specific groups of abnormal myeloid cells. Sickle cell disease, a genetic disorder in which a mutation in the gene for the beta chains of hemoglobin causes chronic anemia, pain, disability, organ damage. Stomatitis, teratogen, an agent that can cause birth defects. Thrombocytopenia is a reduction in number of circulating platelets. Thrombocytopenic purpura, the destructive reduction of circulating platelets after normal platelet production. Okay, so we have a very brief and quick review of the terms that are going to be you're going to be seeing in this lecture. The priority concepts: perfusion, immunity, cellular regulation, gas exchange, of course, related to perfusion, clotting, of course, um, pain, infection. Okay, so the most important function of the hematologic system is the production of blood cells and blood cell products that are critical for the vital activities of perfusion, immunity, clotting, and gas exchange. Perfect. Red blood cells deliver oxygen and, together with platelets, participate in clotting. Okay, so don't assume that only platelets are in charge of clotting. It's RBCs and platelets, okay, participate in clotting. White blood cells and their many products protect the body. When I say many products, mean the nurse love to monitor your neutrophils, your lymphocytes, your monocytes, eosinophils, your basophils, etc., etc. Okay? Protect the body from infection and initiate wound healing after any type of injury. Any hematologic problem interfering with the production, function, and maintenance of blood cells can also impair the process of perfusion, immunity, clotting, and gas exchange. So sickle cell disease is an umbrella. Many people confuse sickle cells with sickle cell anemia. Even though the anemia is under the umbrella of sickle cell extends to a variety, okay, including sickle cell anemia, hemophilia, thalassemia, okay? So let's understand the basics. Sickle cell disease is a genetic disorder in which a mutation in the gene for the beta chains of hemoglobin causes chronic anemia, pain, disability, organ damage, increased risk for infection, and early death as a result of poor blood perfusion. The sickle cell disease, we are going to call this from now on as SCD, okay? If not, I'm gonna get out of saliva. The SCD genetic mutation results in the formation of abnormal hemoglobin gene, as I explained before. In adults without SCD, the normal adult hemoglobin A molecule has two alpha chains. Remember, hemoglobin A is related to alpha or also adult, so you can recognize it better, okay? And two beta chains of amino acids. Normal adult RBCs usually contain 98% to 99% of hemoglobin A, with a small percentage of a fetal form of hemoglobin F, right? A small percentage. That doesn't mean that when you're adult, you're only having hemoglobin A and B. No, you have a small percentage also of hemoglobin F, which is your fetal form of hemoglobin. In SCD, at least 40% and often much more of the total hemoglobin is composed of two normal alpha chains and two abnormal beta chains, okay? In SCD, hemoglobin S is the one that is causing that little imbalance, let's call it this way. And that imbalance, that hemoglobin S, causes the cell to fold poorly. The hemoglobin S is sensitive to low oxygen content of RBC, which causes them to fold even more, distorting the cells into sickle shapes. Um, Sickle cells become rigid and clamp together, causing the RBCs to become sticky and fragile. The clamp masses of sickle RBC block blood flow and perfusion, known as vaso-occlusive event. And that's good to know. Tissue hypoxia is a consequence of vaso-occlusive event, the clamping, the clamping of all those sickle cells are going to cause a vaso-occlusive event. So we are going to have tissue hypoxia, more sickle-shaped cells, due to lack of enough oxygen, more blood vessel obstruction, ischemia in the affected tissue. Conditions that cause sickling, including hypoxia, dehydration, and that's good to know. Please remember the conditions that cause, we have already in the genetics of these patients that crazy combination of hemoglobin A, hemoglobin B that is combined with hemoglobin S, but the conditions that are going to precipitate, the crisis are hypoxia, and I really want you to remember this: hypoxia, dehydration, because the lack of fluid in the vessels are causing the cells, the sickle cells, to clump faster, right? There's no enough fluid. That's why they clump faster. Infection, venous stasis, pregnancy, alcohol consumption, high altitudes because of the low oxygen, low or high environmental or body temperatures, right? Because the high temperature is evaporating, right? The liquid, the fluid in the vessels. That's why that causes the crisis. Acidosis, strenuous exercise. Of course, you are sweating, you are getting the patient out of fluids. Emotional stress, okay, which increases our hormonal changes, right? And people with emotional stress get into anxiety, so they start breathing faster, they are getting out of oxygen or poor oxygenation. Nicotine use, of course, I don't have to explain how that affects the oxygen. And anesthesia, especially I want you to remember anesthesia. Patients under anesthesia are going to precipitate a sickle cell crisis. Okay, and that's good to know. Okay. The precipitating conditions is removed and the blood oxygen level is normalized, which allows tissue perfusion to resume. This happens when you treat the crisis and everything is going to go back to normal. The average lifespan of the RBC containing 40% of more of hemoglobin S is about 10 to 20 days, which is is really less in comparison with the normal lifespan of a RBC, which is 120, and that's good to know too. So you see the normal cell here, hemoglobin A, which is alpha or A of adult, is really, in good shape, round, circular, nice. And then you have the hemoglobin S, which becomes really, very sick, and it has a very lunar half moon shape. The patient with SCD has periodic episodes of extensive RBC cycling, called SCD crisis or vaso-occlusive crisis. We spoke about this. Crisis occurring only in response to conditions that cause local or systemic hypoxemia, deficient oxygen in the blood. And this vaso-occlusive crisis can cause damage to tissue and organs at the end, right? The spleen, liver, heart, kidney, brain, joints, bones, and retina are affected most often. The average life expectancy of adult men with SCD is 42 years. Wow, 42 years, and for women is 48 years. This is the average. I have patients in their 50s and they are having many, they're having crisis very often. Okay, sickle cell crisis very often. Etiology and genetic risk. Sickle cell disease is a genetic disorder with an autosomal recessive pattern of inheritance. I want you to watch this video. It's gonna help you to understand and clarify. So let's see. Let's watch this video.
Sickle cell disease is a group of inherited blood disorders in which the body produces abnormally shaped red blood cells that look like crescent moons or sickles. Sickle cells have a shorter than normal lifespan. Their premature destruction results in shortage of red cells, known as anemia. Signs of anemia include shortness of breath, fatigue, and delayed growth in children. Unlike normal red cells, which are pliant, sickle cells are rigid and also sticky. They may clump together and stick to the walls of blood vessels, causing obstruction in small vessels and subsequent reduced oxygen supply to various organs. This happens repeatedly and manifests as periodic episodes of pain, called crises, which can last hours to days and may result in organ damage, especially in the eyes, lungs, kidneys, bones, and brain. The spleen has to handle large numbers of dead red cells and becomes enlarged and fibrous. Its immune function declines, making the body more vulnerable to infections. In an attempt to compensate for blood cell loss, the bone marrow tries to produce more cells and grows larger, causing bones to weaken. Other signs include jaundice, a result of rapid destruction of heme. Hemoglobin is the major component of red blood cells and is responsible for oxygen transport. The adult hemoglobin, or hemoglobin A, is composed of 4 protein chains, 2 alpha and 2 beta. The beta subunit is encoded by the HBB gene. Several mutations in HBB gene are responsible for the disease. Each individual has 2 copies of HBB gene. The disease develops when both copies are mutated, producing no normal beta globin. The 2 copies may be mutated differently, producing 2 different forms of abnormal beta subunits in the same person. Various combinations of these mutations produce different forms of sickle cell disease, but the most common and also most severe, called sickle cell anemia, is caused by 2 copies of the same mutation, producing the mutated hemoglobin S. Each copy comes from a parent. The 2 parents each carry 1 copy of the mutated gene, but they typically do not show any symptoms. This pattern of inheritance is called autosomal recessive. Hemoglobin S has the tendency to form polymers under low oxygen conditions. This process is called sickling or gelation for the gel-like consistency of the resulting polymer. As the polymer filaments grow, they eventually involve the cell membrane and distort the cell into the characteristic crescent shape. Apart from oxygen tension, the presence of other hemoglobins also seems to affect the sickling process. Normal adult hemoglobin inhibits sickling, and this explains why heterozygous parents who produce both mutated hemoglobin S and normal hemoglobin A do not usually develop the disease. Fetal hemoglobin F, which has 2 gamma chains in place of 2 beta chains, also suppresses sickling. Infants born with the condition seem to benefit from high levels of fetal hemoglobin in the first few months of life. They do not develop symptoms until the age of 6 months or so, when fetal hemoglobin levels drop. Bone marrow transplantation is currently the only known cure for sickle cell disease. It involves replacing the diseased stem cells in the bone marrow with healthy cells from an eligible donor, usually a relative. The procedure, however, is complex, and finding a suitable donor can be difficult. In most cases, treatments aim to avoid crises, relieve symptoms, and prevent complications. These include prophylactic antibiotics, vaccinations to prevent infections, pain medication to relieve pain, drugs that promote formation of fetal hemoglobin to suppress sickling, periodic blood transfusions to reduce anemia and prevent crises, and early detection and treatment for complications when these occur.
Thank you so much for this video. And as the video is mentioning, only bone marrow transplantation is the cure for sickle cell disease. Bone marrow transplantation, first of all, is not available for everybody based on the insurance. The second thing is that you need to find a donor that matches with you, right? And the third thing is that the hospital care could extend for 3 to 6 months for this transplant to take place. It's not an easy process. So what happened is it's better to help these patients to prevent the crisis with proper oxygenation, prevent infections, dehydration, stressful events, etc. As we are explaining here. Okay, so sickle cell trait and different from forms of sickle cell disease occurs in people of all races and ethnicities, but are most common among African Americans in the US. About 100,000 people have SCD, which occurs in 1 in 500 African Americans. And although I'm not going to test you on the genetic part of how the disease is and the components, right? It's good to know because whenever you get your first job into the field, you don't know where nurses is going to take you. You can start falling in love with hematology or oncology or pediatrics, and in your pathway of nursing, you are going to figure out that you need to learn these little details. Okay, if you become a nurse practitioner or if you have a doctorate in certain specialties, then you will need to master all these details. Assessment, recognizing the cues. Patients with SCD may be unaware that they have an hematologic problem until an acute illness is present or when anesthesia is administered. And that's good to know. Anesthesia and stress can precipitate a sickle cell crisis. I think I mentioned this 3 times already, so make sure you remember this fact for your exam. Ask about previous crisis, what led to the crisis, severity and usual management. Ask about signs and symptoms of infection. Review all activities and events during the past 24 hours, including food and fluid intakes, exposure to temperatures, extremes, drugs taken, exercise, trauma, stress, recent airplane travel, and use of alcohol, tobacco, and other recreational drugs. Also, ask for the sleep patterns, ability to climb stairs, and any activity that induces shortness of breath. Physical assessment, cardiovascular changes occur because of the anemia. Okay, so we are talking about RBCs, we are talking about hemoglobin. Don't think these are different concepts. They correlate somehow. Anemia is related to RBCs, and we know that the main symptoms, the most frequent symptoms of anemia is going to be shortness of breath and general fatigue or weakness. Other problems may include murmurs, the presence of of an S3 heart sound, right? An increased jugular venous pulsation or distension. And you know where to check for jugular venous pulsation or distension is on the side of the neck, right? Assess for cardiovascular status by comparing peripheral pulses, temperature, and capillary refill in all extremities. These are all as related to assessment of the cardiovascular. I don't even have to mention this because it's obvious. When we conduct cardiovascular assessment, we have to check for pulses, capillary refill in all extremities. Extremities distal to blood vessel occlusion are cold to the touch with the slow capillary refill and maybe reduced or absent pulses. Another basic for cardiovascular changes, pulses, which indicate reduced perfusion. Respiratory system changes, pulmonary hypertension, and all are at risk for recurrent pneumonia. Okay, so we need to assess for the patient if they have a previous episode of pneumonia. Acute chest syndrome is a common reason for hospitalization and is the most common cause of death. Hello, this is very important. Acute chest syndrome. This life-threatening condition is usually associated with respiratory infection and can also be caused by fat embolism and debris from sickle cells. So we need to prevent this crisis in order to reduce the amount of debris from sickle cells. Symptoms are similar to pneumonia with cough, shortness of breath, abnormal breath sounds, and an ill filtrate on chest x-ray. Fever may occur or maybe it's not present. This complication can lead to respiratory failure and multiple organ dysfunction syndrome. All of you who wants to work on ER or they want to work in ICU, SICU, you need to be familiarized, pay an extra attention with the patients that are having sickle cell disease because the respiratory system will be compromised at some point. Priapism is a prolonged penile erection that occurs in men who have SCD. The cause is excessive vascular engorgement in erectile tissue. This condition causes severe pain and can last for hours, and you don't want to see a gentleman coming to ER with priapism. It's very sad. Skin changes include pallor, cyanosis, jaundice, ulcers on the lower legs that are caused by poor perfusion, often become necrotic or infected. Of course, because for tissue regeneration and healing, we need oxygen and good quality of blood. And if your RBCs are having these traits of hemoglobin S that are shrinking and are causing problems in perfusion, of course you're going to have a necrotic or infected tissue. Abdominal changes include damage to the spleen and liver, damage to the kidney nephrons. Musculoskeletal changes occur because arms and legs are often sites of blood vessel occlusion. Joints may be damaged from hypoxia episodes and have necrotic degeneration. Long-term effects of reduced perfusion to the CNS may result in infarcts with repeated episodes of hypoxia, causing the patient to have seizures or symptoms of a stroke. Just remember that the nervous system is a network that works based on electricity, right? Water conduction and oxygen. So it's very important to prevent this sickle cell disease crisis. Often, cognitive and behavioral changes are early indications of cerebral hypoxia from poor perfusion. Okay, so our vessels in the brain are very tiny and thin. So if we don't have a good quality again of blood and a good amount of oxygen, right? Our brain is going to be compromised. Family, especially our cognitive and behavioral changes, right? Family for knowledge, we have to assess the family for knowledge and understanding of the condition and how to survive and to live with the disease. Laboratory assessment, the diagnosis of SCD is based on the percentage of hemoglobin S on electrophoresis. That's the standard, okay, for this SCD, electrophoresis. The hematocrit of patients with SCD is low, between 20 to 30%, because RBCs shorten a lifespan of and distraction. This value decreases even more during crisis of stress, which is called a plastic crisis. The reticulocyte, which are the baby RBCs, count is high, indicating anemia or low duration of long duration. The total bilirubin level may be high because damaged RBC release iron and bilirubin. Just a refresh. What is bilirubin? An orange-yellow pigment formed in the liver by the breakdown of hemoglobin and um, excreted in the bile. That's bilirubin, okay? Um, what imaging are we going to use for this diagnosis? You're going to see a bone changes occur as a result of chronically stimulated marrow and low bone oxygen levels. So the bone marrow is going to keep working like crazy trying to produce as much RBCs. That's why the reticulocyte count is going to go high. And this overproduction of reticulocytes and extra work from the marrow is going to change, is going to cause bone changes. So you're going to see probably in the x-ray a skull in the appearance of a crew cut. I have included an image in your supplemental file so you can see how a skull, the crew cut appearance on x-ray looks like. Ultrasonography, CT, positron emission tomography, and MRI have shown soft tissue and organ changes from poor perfusion and chronic inflammation. Other diagnostics: cardiac infarcts and tissue damage, cardiomyopathy, and decreased cardiac output is low ejection fraction. There are going to be a notice when we assess this type of patients. So we are going to manage this condition by preventing pain with sickle cell crisis, because we want to prevent tissue injury caused by poor perfusion and tissue gas exchange from RBC clamping that obstructs blood flow. And we keep repeating perfusion, gas exchange, because sickle cell disease is about preventing poor perfusion, okay, and providing better gas exchange. Opioid addiction is rare in patients with SCD because the pain of crisis has no objective signs. Pain management is based on past pain history, previous drug use, disease complications, and current pain assessment. Drug therapy for patients in acute sickle cell crisis and pain often starts with at least 48 hours of IV analgesics. Usually they're going to use morphine or hydromorphine through IV, and it's going to be on a schedule, very strict therapy. By infusion pump using patient-controlled analgesia. Once relief is obtained, the IV dose can be tapered, okay? And the drug given orally, you have to avoid as needed when it comes to SCD patients. Always go back to the doctor and ask for a renewal of the prescription, or go and tell the doctor how the patient is, progressing. You never put these medications on SCD as needed. They do not provide adequate relief. Moderate pain may be managed with oral doses of opioids or NSAIDs. So this table here, the best practice for patient safety and quality care is all that's good to know. Is basically all that we have spoken so far about the oxygen, the pain medication, the hydration. Um, this is good also to know. Remove any constructive clothing. Encourage the patient to keep extremity extended to promote venous return. Elevate the head of the bed no more than 30 degrees. Um, Check circulation and extremities every hour. Your cardiology assessment, including pulse, peripheral pulses, capillary refill. Okay, so there is a medication called hydroxyurea that we usually use to treat cancer and sickle cells anemia. And uh, this medication may reduce the number of sickling and pain episodes by stimulating fetal hemoglobin. Remember that we spoke before that all adults we have a combination of alpha and beta hemoglobin and a small number of fetal hemoglobin. So what this medication does is to stimulate fetal hemoglobin production, which is the main type of hemoglobin present in fetal life. We explained that, right? However, the drug increases the risk for leukemia. Long-term complications should be discussed with the patients before this therapy is started, especially because also this medication causes suppression in the bone marrow function, including immunity. And regular follow-up to monitor complete blood count for drug toxicity is important, your CBCs, right? Uh, since we spoke about the side effects of hydroxyurea, which is basically a teratogen, we need to talk to women of childbearing age using this medication to adhere to strict contraceptive measures while taking it, and for 1 month after is discontinued in order for them to avoid pregnancy. Okay. We're going to also prevent crisis by hydration using the IV route. We spoke about this. The patient can drink a plenty amount of water, juices, because the patient is often dehydrated. So we are going to use, if it's IV, hypotonic solutions instead of hypertonic. The patient is all the time in hypertonic state because it's dehydrated, meaning that the blood is not diluted enough. Those cells are going to be shrinking and clumping to each other. That's why they need more hypotonic solutions, usually 250 ml per hour for 4 hours. And this is good to know because clients in sickle cells are often dehydrated. The fluid of choice is going to be uh, 0.45 normal saline or zero point 0.9 normal saline or lactated ringers. Don't think about D50, which is hypertonic, um, and it's not going to cause any benefit. Integrative therapies you can consider to keeping the room warm, using distraction if possible because these patients are going to be in a lot of pain. Relaxation techniques, you can use Reiki if you know how to perform that therapy. Position with support for painful areas, aromatherapy, therapeutic touch, warm soaks or compresses. The goal is to reduce the pain, right? Okay. So if we want to keep the patient free from infection and sepsis, they are in high risk for bacterial infection because of reduced immunity from anoxic damage of to the spleen. As we explained before, the problem with the respiratory system is is something that is going to happen sooner or later. Testing for sepsis included CBC with differentiation, WBC count, blood cultures, reticulocyte count, urine culture, and chest X-ray. Usually, these patients are started on prophylactic antibiotics. Yes, prophylactic, meaning that if they don't have the disease, they are still going to start on this type of antibiotics for prevention. Any person with upper respiratory tract infections who enter the patient room must wear a mask. A strict aseptic technique is used for invasive procedures. Inspect the mouth every 8 hours for lesions indicating fungal or viral infection. Listen to the lungs. Inspect urine for odor and cloudiness and ask about urgency, burning, or pain on urination. Check your vital signs basically every 4 hours. Drug therapy. You are going to talk to the patient to receive a pneumonia vaccine or the annual influenza vaccination. Um, Continued blood vessel occlusion by clamping of sickle cell increases the risk for multiple organ dysfunction, as we spoke before. Acute chest syndrome, in which a vaso-occlusive event causes infiltration and damage to the pulmonary system, is a major cause of death in adults. Thus, prevented heart and lung damage is priority. Management focuses on prevention of this event and promoting perfusion. Hydration, oxygen is given during crisis. So if we have a patient with sickle cell disease, and this is critical thinking question between hydration and pain, which are both important to treat sickle cell disease. Which one are you going to administer first? Are you going to put your IVs or to make the cells not to clump and to make the vessels with more fluids? Or are you going to administer your oxygen? Think about your ABCs, okay? Think about your ABCs. So if you come across a question this nature, oxygen is first. Oxygen is first, okay? Also, transfusion with RBCs can be helpful to increase hemoglobin levels and dilute the HbS levels. But it has to be prescribed cautiously to prevent iron overload from repeated transfusions. So to protect your licensed nurses, whenever a doctor prescribes these type of therapies, a transfusion with RBCs, you go to your blood work, you check your computer, you check your levels, and you check first how are the iron levels, okay, first before administer any type of RBCs. And then you you are totally under control of this situation, right? um so you have a question here, which I'm gonna let you read this question. The answer is C. And there is another good table that you have to absorb in prevention of sickle cell crisis. I talk about anesthesia, and then teach the patient to avoid specific activities that lead to reduced gas exchange from hypoxia and hypoxemia. For example, going to a sauna. If you're going to the gym and they want to enter to a sauna, it's a no-no. If they are in crowded places with a lot of people at some point, you know, um, stress the recognition of the early symptoms of crisis of infection, so intervention can be started early to prevent pain. Okay, the use of combination of hormone drugs for contraception may increase clotting, especially among smokers, predisposing them to impair perfusion and crisis. All these things that are that could prevent that could predispose, right, clothing, like for example lack of movement, continue being on the bed for too many hours, lack of exercise, right? However, they cannot do a strenuous exercise, but they have to have to move to prevent clotting. Okay, so all these things you need to take into consideration, especially if there are some contraceptives that are that put the woman in high risk for clots. So you have to think about that. And we have finished this part of this chapter talking about sickle cell disease. We are coming with more to complete this chapter. Thank you.